Welcome to the Deep Dive. Today we're tackling rheumatoid arthritis, or RA. Now, most people probably think of it as, just sore joints, maybe aching knees.
A common misconception.
But the picture that emerges when you dig into it is actually, well, it's much darker, isn't it? We're talking about a chronic systemic autoimmune disease.
Exactly. It's this fundamental clash involving our genes, our environment, and literally our own cells waging war internally. That's the core we need you to grasp today.
So it's not just simple wear and tear like osteoarthritis.
Not at all.
Yeah.
This is the body's defense system turning inward. Primarily targeting the joints, sure, but the inflammation doesn't stop there. It sends these ripples, these inflammatory signals throughout the entire body.
Affecting things like the lungs, the heart.
Precisely. Lungs, heart, blood vessels.
Yeah.
It's truly systemic.
Okay. So our mission for you in this deep dive is to build a really solid, structured understanding of RA. We're going to journey from how it first shows up, which can be quite varied,
Sometimes surprising, yeah.
through the sophisticated diagnostic tools, the biomarkers we use now, and then really get into the latest thinking on its root causes, the pathology.
And crucially, the treatment strategies, particularly this treat-to-target approach that now dominates modern care.
Right, and that whole strategy stems from something you called the core paradox of RA. Tell us about that.
Yeah, the paradox is stark. It's the fact that the irreversible joint damage, the actual destruction of cartilage and bone, it starts incredibly early, often way before people might expect.
How early are we talking?
We're talking visible bony erosions, these little craters in the bone, showing up on x-rays within the first year of symptoms for many patients, sometimes even before they've got a nailed-down diagnosis.
Wow, so the clock is literally ticking from day one of symptoms.
Absolutely. There's no time to waste. That finding is what really forced the shift towards this aggressive treat-to-target, or T2T, philosophy.
It sounds like a race against time then.
It is a structured race to shut down that inflammation before permanent damage sets in.
Okay, so let's start at the beginning for the patient. What does RA typically look like when someone first goes to the doctor? What's the classic presentation?
Well, the absolute hallmark is joint pain and swelling. But it tends to favor specific locations, especially early on.
Like where?
Think small joints, the metacarpophalangeal joints, your big knuckles, basically, the proximal interphalangeal or PIP joints, the middle joints of your fingers, also the wrists, and often the joints in the forefoot. That's the classic pattern.
And the pattern itself, the distribution, is really important diagnostically, right? It's not just random joints.
No, absolutely not. It's characteristically symmetrical. That's a huge clue.
It's symmetrical, meaning?
Meaning if your left wrist and maybe the second knuckle on your left hand are inflamed, it's highly probable that your right wrist and the corresponding knuckle on your right hand will be involved too. That mirroring is key.
Okay. And what else do patients typically report?
Very common features are things like decreased grip strength, trouble opening jars, that kind of thing, and really significant morning stiffness.
Stiffness that lasts.
Yes, often for hours, not just a few minutes like you might get with simple osteoarthritis. This can be quite debilitating, making it hard to get going in the morning.
That sounds awful.
Yeah.
But you mentioned earlier that RA can present in surprising ways. It doesn't always follow that textbook picture.
That's right. While most people have a gradual, sort of insidious onset over weeks or months, a smaller group can present quite acutely, suddenly, which can sometimes muddy the waters, maybe look like an infection or even gout initially.
Okay.
But probably the most fascinating variation is something called palindromic rheumatism.
Palindromic rheumatism. Intriguing name. What does that look like?
It's this really strange intermittent pattern. A patient might get a sudden, intense flare-up in one or maybe several joints, serious pain, swelling.
Right.
But then after just hours or maybe a few days, it completely vanishes. Gone. Completely. Then they have these symptom-free periods, could be days, weeks, even months before another episode hits, maybe in a different joint. It's like the inflammation is flickering on and off.
Before potentially settling into persistent RA later on.
Exactly. In some, it resolves, but in many, it eventually evolves into classic chronic RA. You can see how that makes early diagnosis really tricky, though.
Yeah, if the inflammation's gone by the time they see the doctor.
Precisely.
What about age? Does RA look different if it starts later in life?
It definitely can. We talk about elderly onset RA, or EOR, and this can be atypical. Instead of the small hand joints, it might mimic polymyalgia rheumatica, PMR.
PMR, that affects the big joints, right? Shoulders, hips.
Exactly. So in ERA, you might see the inflammation predominantly in the shoulder and hip girdles. It can also sometimes start as monoarticular disease, just one single joint affected initially.
Okay, so lots of variation. Now, are there joints that RA typically spares? Places where inflammation would make you think away from RA.
Yes, and that's diagnostically helpful too. RA doesn't characteristically involve the distal interphalangeal joints. Those are the very last joints near your fingertips. Or the lumbar spine, the lower back. If you see the main inflammation hitting those areas hard, you should be thinking about other diagnoses. Maybe osteoarthritis, or perhaps psoriatic arthritis.
We established earlier that RA is systemic. It's not just confined to the joints. How often does the disease actually spread beyond the joint capsule and start affecting other parts of the body?
It's surprisingly common. These extraarticular manifestations, meaning outside the joint, occur in roughly 40% of patients at some point during their disease course.
40%? That's nearly half.
It is, and it's a direct consequence of that widespread systemic inflammation we talked about. It's not a side issue, it's part of the RA process itself.
So what are some of the main ways this shows up? What's the most recognizable sign outside the joints?
Probably the subcutaneous nodules, often just called rheumatoid nodules. These are firm lumps that form under the skin, typically over bony areas or pressure points like the elbows.
Okay, nodules. Anything else?
Well, there's a slightly strange phenomenon related to methotrexate, which is our main RA drug. In some patients taking methotrexate, they can paradoxically develop more nodules, where existing ones can get bigger. It's called accelerated nodulosis, even while the drug is doing a great job controlling the joint inflammation itself.
Huh. That really highlights how complex this is. Okay, nodules aside, what about the major organs? Where does the inflammation cause the most serious trouble?
Well, the lungs and the heart are major concerns. Serious, potentially life-threatening involvement can occur.
Like what specifically?
Patients can develop inflammation of the lining around the lungs and heart. That's pleuritis and pericarditis, or pleuropericarditis together. They can also get airway disease and various types of lung tissue disease, like interstitial lung disease, which causes scarring.
And the heart risk. You mentioned that's significant.
It's massive, truly critical. Patients with RA have a substantially higher risk, up to double the risk of things like sudden cardiac death, heart attacks, and heart failure compared to people without RA.
Double the risk.
Yeah.
Why so high?
It's the chronic inflammation itself. It accelerates atherosclerosis, the hardening and narrowing of arteries. So uncontrolled RA acts like an independent cardiovascular risk factor, similar to high blood pressure or smoking.
So controlling the RA isn't just about saving the joints.
It's about saving the heart, too. Absolutely.
That's a really crucial point.
Yeah.
What else falls under these extra-articular problems?
Eye problems are quite common. Episcleritis and scleritis inflammation of the white part of the eye. Scleritis can even become necrotizing, which is really serious and can threaten vision.
Okay.
And secondary Sjogren's syndrome is also very frequent. That causes significant dryness of the eyes and mouth, which can be quite miserable.
Are there less common, but maybe more severe, things involving blood or blood vessels?
Yes. Hematologically, besides the common anemia of chronic disease, you can rarely see something called Felty syndrome. That's a triad of RA, a low white blood cell count, specifically neutrophils, and an enlarged spleen. Even rarer is a type of leukemia called large granular lymphocyte leukemia. And then on the vascular side, there's rheumatoid vasculitis.
Inflammation of blood vessels.
Exactly, affecting small to medium-sized vessels. It can range from relatively small things like tiny infarcts in the nail folds, all the way up to severe systemic arteritis affecting multiple organs. That's a true medical emergency.
Okay, so that's the systemic picture. Let's zoom back into the joint itself.
Mm-hmm.
If the inflammation is the fire, how do we actually see and track the damage it leaves behind?
Well, our sort of baseline tool, our workhorse, is still plain radiography standard X-rays, particularly of the hands and feet. We use these to track the disease progression over time.
What are you looking for on those X-rays?
Two classic signs. First, joint space narrowing, which tells us cartilage is being lost. And second, those bony erosions we mentioned, the little divots or craters where the inflamed synovial tissue, the pannus, has literally eaten away at the bone.
And you said these can appear quite early.
Frighteningly early, often within the first year of symptom onset. That's why relying only on X-rays to start treatment is waiting too long.
Right, because X-rays show damage that's already done. Are there tools that can see the trouble brewing earlier, before the bone gets eroded?
Oh, yes. MRI and ultrasound are much more sensitive for picking up early changes.
What can they show?
They can detect things like synovial thickening, that's the buildup of the inflamed joint lining long before erosions are visible on X-ray. They can spot very early tiny erosions too, and also subchondral bone edema.
Bone edema, like swelling inside the bone.
Exactly. Inflammation within the bone marrow right under the cartilage. It's often a predictor of future erosion development. So these tools give us a much earlier warning signal.
Makes sense. Now, if a joint is really swollen, rheumatologists often stick a needle in and draw off some synovial fluid analysis. What does the fluid look like in RA?
Typically in RA, the fluid is cloudy or turbid, usually yellowish. Crucially, it should be sterile, meaning no bacteria are growing, ruling out infection.
Okay. And what's the key finding in the analysis?
The cell count. It's highly inflammatory. The white blood cell count is typically very high, often somewhere between 10,000 and 50,000 cells per microliter, sometimes even higher.
And that confirms active inflammation.
Absolutely. That high cell count tells you there's a major inflammatory battle going on inside that joint space.
You sometimes hear about older tests on the fluid, like complement levels or glucose.
Yeah.
Are those still relevant?
Historically, low complement levels, C3 and C4, and low glucose compared to blood levels were noted in RA synovial fluid. But honestly, those aren't routinely checked or particularly helpful in clinical practice today. The inflammatory cell count is really the key takeaway from fluid analysis.
Okay, that high cell count really sets the stage for understanding the immune attack, which brings us to the biomarkers. The blood tests we use to help confirm the diagnosis, predict how severe the disease might be, and even guide treatment. Yeah. And the big players here are the autoantibodies, right?
Yes, absolutely. These are the immunological fingerprints of RA. Their presence defines the largest group of patients, about 75 to 80%, as being seropositive.
Seropositive meaning?
Meaning they test positive for either rheumatoid factor or RF, or the anti-citrullinated protein antibodies, ACPA, or often both. And finding these antibodies has major implications for prognosis and therapy choices.
Let's start with the older one, rheumatoid factor, RF. It's been around for ages. What are its main limitations? Why isn't it a perfect test?
Well, RF has decent sensitivity, meaning it picks up a good number of RA cases, but its big drawback is low specificity.
Low specificity, meaning it can be positive in people without RA.
Exactly. That's the problem. It makes it a poor test to screen the general population. For instance, RF can be positive in, believe it or not, up to 76% of people with chronic hepatitis C.
Wow.
And even in up to 25% of perfectly healthy older adults. So a positive RF test by itself definitely doesn't automatically equal RA.
Okay. So why do we still test for it then? If someone does have RA confirmed and their RF is positive, what does that tell us?
It generally points towards a potentially more severe disease course. RF positive or seropositive RA is often associated with more aggressive joint damage over time and also a higher chance of developing those extra-articular problems we discussed, the lung, heart, nodules, and vasculitis issues.
Got it. Now let's talk about the more modern test. ACPA, often called anti-CCP. Why has this test been such a game changer for diagnosing RA?
ACPA, or anti-CCP, is just much more specific for RA than RF is. A positive ACPA test is highly indicative of RA.
And it does more than just diagnose, right? It predicts outcomes.
Yes, it has significant predictive power. Being ACPA positive strongly predicts an increased risk of progressive joint damage, more erosions, worse outcomes down the line.
And there's a dangerous interaction with a major environmental trigger we need to mention here.
Right. Smoking. The combination of being ACPA positive and being a cigarette smoker is particularly bad news.
Oh, so?
That combination dramatically ramps up the risk, not just of developing RA in the first place, maybe a 20 to 40-fold increased susceptibility, but also of having a particularly aggressive, erosive form of the disease. It's a really potent negative synergy.
That's incredible. But perhaps the most striking thing about ACPA is how early it can show up.
Yeah.
Years before symptoms.
Yeah, this is fascinating. ACPA can often be detected in someone's blood an average of 3 to 5 years before they experience their first swollen joint.
3 to 5 years.
Or even longer. There are documented cases where it's been present for over a decade before clinical symptoms appear. This is what we call the preclinical RA phase. The autoimmune process has started simmering long before the joints actually start to hurt.
Does getting treatment make these antibodies go away?
Well, that's interesting. ACPA levels can decrease with effective treatment using DRMARDs, which suggests the immune system is calming down somewhat. But the decrease is generally less common and less pronounced than what you might see with RF levels. The ACPA positivity tends to stick around more persistently, even in well-controlled disease.
What about the 20–25% of patients who don't have RF or ACPA, the seronegative group? Are there newer antibodies helping us understand or manage them?
Yes, research is ongoing there. We're looking at other antibodies. For example, anti-CARP antibodies, that's anti-carbamylated protein antibodies.
Anti-CAR.
Right. Some studies suggest these might help predict who among the ACPA-negative patients is more likely to develop radiographic progression, meaning joint damage. There's also interest in anti-MCV antibodies, anti-mutated citrullinated vimentin, which might correlate with more severe disease overall, regardless of ACPA status. Still emerging, but promising areas.
Okay, so the autoantibodies tell us if RA is likely present and maybe hint at its future severity.
Yeah.
But how do we track the current level of inflammation, the day-to-day activity?
For that, we rely heavily on acute phase reactants, or APRs. These are markers in the blood that go up when there's inflammation anywhere in the body. The two main ones we use in our RA are the ESR.
The erythrocyte sedimentation rate?
Yep, SETA rate, and CRP, C-reactive protein.
And what do they tell us?
In active RA, both ESR and CRP are usually elevated. Their levels tend to correlate pretty well with how active the disease is clinically, and higher levels generally predict more future joint damage on X-rays. They're crucial for monitoring response to treatment.
Is one better than the other? ESR versus CRP?
Well, CRP has some practical advantages. It changes more rapidly in response to inflammation changes, both up and down. Its measurement isn't affected by things like anemia, which can artificially raise the ESR, and CRP can be measured easily in stored blood samples.
Whereas ESR depends on?
ESR depends on the level of fibrinogen and other proteins, and can be affected by the red blood cells themselves. So many clinicians prefer CRP as a more direct and dynamic measure of acute inflammation.
But you wouldn't rely on just one of them, would you?
Ideally, no. It's actually quite common, maybe in about a quarter of patients, to see discordant results.
Meaning one is high and the other is normal.
Exactly, even when the patient clearly has active disease. So you really need to look at both in the context of the whole clinical picture.
Okay. And this focus on objective measurement leads us to something really central to modern RA care. Composite scores. Why aren't doctors just asking patients how they feel or counting swollen joints anymore?
Well, we do count joints and ask patients how they feel, but we need to combine that information in a structured, objective way, especially because our goal now is treat to target, T2T.
Right.
T2T demands we quantify disease activity rigorously. We can't just rely on a gut feeling because things like pre-existing damage or fibromyalgia can confuse the picture of active inflammation. So using formal composite disease activity scores is now standard practice, mandatory really.
Can you give us some examples of these scores?
Sure. The most widely used ones include the DAYS-28 disease activity score using 28 joints. There's also the SDAI, the Simplified Disease Activity Index, and the CDAI, the Clinical Disease Activity Index.
And how do they work, basically?
They typically combine several pieces of information: a count of tender joints, a count of swollen joints, the patient's own assessment of their global health or disease activity, sometimes a doctor's global assessment, and usually one of those APRs like CRP or ESR.
And this boils down to a single number.
Exactly. It generates a score that categorizes the patient's current state. Are they in remission, low disease activity, moderate, or high? And that number then directly informs treatment decisions according to the T2T strategy. Hashtag 2.3 multi-biomarker algorithms.
Okay, that makes sense. Now, pushing the envelope even further, there are efforts to go beyond just combining clinical counts and one or two APRs. Tell us about these multi-biomarker disease activity tests, or MBDA tests.
Yeah, this is taking it to another level of complexity. These MBDA tests, like one called Vectra DA, don't just look at CRP or ESR. They measure a whole panel of biomarkers simultaneously, typically 12 different ones.
12? What sort of things?
It's a mix. Things like various cytokines, growth factors, hormones, adhesion molecules, basically trying to capture a more holistic snapshot of the underlying inflammatory biology. These 12 markers are then plugged into an algorithm to generate a single score, usually from 1 to 100.
And what's the proposed advantage of looking at so many markers?
The hope is to get a more accurate and perhaps more predictive measure of disease activity and, importantly, the risk of future damage. And some studies have suggested that the MBDA score might be a stronger predictor of radiographic progression, future joint damage, than the standard DAS-28 score alone.
Okay, if it potentially predicts damage better, why isn't everyone using it all the time? Why hasn't it replaced the DAS-28 or CDAI in routine practice?
There are a few reasons. Cost effectiveness is definitely one question mark for routine, frequent monitoring. But a really significant issue, and a fascinating one, is how it interacts with a specific class of RA drugs.
Which class?
The IL-6 inhibitors, drugs like tocilizumab or sirolimus.
Ah, interleukin-6.
Yeah.
We know that's a key inflammatory cytokine targeted by these biologics. What's the problem with the MBDA test when someone's on an IL-6 blocker?
Well, IL-6 itself is actually one of the 12 biomarkers included in the MBDA calculation.
Okay.
When you give an IL-6 inhibitor, it blocks the IL-6 receptor on cells. This prevents IL-6 from signaling, which is good, but it also causes the unbound IL-6 protein to build up dramatically in the bloodstream. The levels skyrocket.
Because it can't bind to its receptor.
Exactly. So when you measure the blood with the MBDA test, you see these artificially high IL-6 levels. This messes up the algorithm, often making the overall MBDA score seem lower or less improved than the patient's actual clinical response would suggest.
So it gives a misleadingly low score, potentially.
Yeah. Or at least makes interpretation very difficult in patients on that specific therapy. It really limits its utility as a universal tool to track response across all drug classes, which is a key requirement for T2T monitoring. Still a potentially useful tool, but with caveats.
Okay, we've covered symptoms, diagnosis, and tracking the disease. Let's rewind now and get into the why. How does RA actually start? What kicks off this whole destructive autoimmune process at the level of our genes and cells?
Well, it's almost always a combination of two things. You need the underlying genetic susceptibility, and then you usually need some kind of environmental trigger to set it off. Nature and nurture working together, essentially.
How much does genetics contribute?
We estimate that heritability, how much is down to genes, is around 40%. So not entirely genetic, but a significant component. Having a first-degree relative, like a parent or sibling, with RA roughly triples your own risk compared to the general population.
When we talk RA genetics, one region always comes up, HLA-DRB1. Tell us about this and the famous shared epitope.
Right. The HLA-DRB1 gene region on chromosome 6 contains the strongest known genetic risk factors for RA. Within certain versions or alleles of this gene, there's a specific sequence of amino acids at positions 70 to 74 that is conserved across several high-risk alleles. That conserved sequence is called the shared epitope, or SE.
And what does the shared epitope do?
The thinking is that the shape of the HLA molecule encoded by these SE-containing alleles makes it particularly good at presenting certain self-peptides, especially citrullinated peptides, to T cells in a way that triggers an autoimmune response. Importantly, the shared epitope primarily confers risk for ACPA-positive RA.
Okay, but the research has gotten even more specific than just the shared epitope region, hasn't it?
Right.
You mentioned specific amino acids.
Yes, this is where it gets really granular and exciting. We now know that specific amino acid residues at just two positions within that HLA-DRB1 molecule, position 11 and position 13, seem to exert the most powerful influence on RA risk.
More than the shared epitope region itself.
Well, they are within or adjacent to that region, but knowing the exact amino acid at position 11 or 13 tells us even more about whether that specific allele increases risk, decreases risk, or is neutral. It seems these positions fine-tune the peptide binding groove of the HLA molecule. It's an incredible level of molecular precision.
And this level of detail, looking at specific amino acids, is also what strongly suggests that RA might not be just one single disease.
Precisely. This is a huge conceptual shift emerging from the genetic data. Seronegative RA, the kind without RF or ACPA, appears to be genetically distinct from seropositive RA.
How so?
While both types show associations with variation at HLA-DRB1 positions 11 and 13, the specific amino acids at those positions that confer risk or protection are often different between ACPA-positive and ACPA-negative disease. This strongly points towards different underlying biological pathways driving the two main subtypes of RA.
Fascinating. Okay, so genetics loads the gun, particularly for seropositive RA. What's the main environmental factor that pulls the trigger?
Hands down, the strongest known environmental trigger is cigarette smoking.
How does smoking contribute?
The leading hypothesis involved the lungs. Smoking causes inflammation and damage in the lungs, and this process seems to increase the citrullination of proteins there.
Citrullinate, that's the modification targeted by the ACPA antibodies.
Exactly. So in genetically susceptible individuals, like those with the shared epitope alleles, the immune system encounters these newly citrullinated proteins in the lungs, mistakenly identifies them as foreign, and starts generating ACPA antibodies. This seems to be a key initiation event, particularly for ACPA-positive RA.
And you mentioned the interaction between smoking and the shared epitope is particularly dangerous.
Yes, it's a dramatic synergy. If you have the high-risk HLA alleles and you smoke, your risk of developing ACPA-positive RA skyrockets, that 20 to 40-fold increase we mentioned. It's a massive amplification of risk.
Does quitting smoking help?
It does lower the risk, absolutely. But unfortunately, it can take a very long time, potentially decades, for an ex-smoker's risk to return to the level of someone who never smoked. The damage lingers. Hashtag TagTech 3.2, the synovial microenvironment.
Okay, so we have the genetic risk, the environmental trigger like smoking, maybe the ACPA antibodies are circulating silently for years. What's the next step? What actually causes the joints to become inflamed? What's the second hit?
The second hit is thought to be something that triggers inflammation locally within the joint lining, the synovium. It could be microtrauma, maybe a transient infection, we're not entirely sure. But something causes those circulating immune cells and antibodies to home in on the joint.
And once the inflammation starts in the synovium, what happens?
The synovium, which is normally just a very thin, delicate lining inside the joint capsule, undergoes this dramatic transformation. It starts to thicken, proliferate, and organize itself into this aggressive, invasive tissue called the pannus.
The pannus. That sounds ominous.
It is. The pannus is the real engine of destruction in RA. It grows over the surface of the cartilage, adheres to it, and releases enzymes and other factors that literally dissolve the cartilage and erode the underlying bone.
What kinds of cells make up this destructive pannus tissue?
Several key players, but perhaps the most crucial are the fibroblast-like synoviocytes, or FLS.
Fibroblast-like synoviocytes, FLS. What's special about them in RA?
In RA, these FLS undergo a transformation. They become hyperproliferative, resistant to dying, and incredibly invasive. They behave almost like tumor cells in some ways.
How so?
They actively migrate, invade the cartilage and bone, and they secrete inflammatory mediators and enzymes that drive the destruction. They also produce factors that recruit other immune cells to the joint, amplifying the inflammation. And they use specific molecules, like cadherin 11, to stick together and form that aggressive lining layer of the pannus.
So the FLS are like the destructive architects of the pannuses. What other immune cells are major drivers?
Macrophages are critical. Large numbers of macrophages infiltrate the inflamed synovium. They become activated into a pro-inflammatory state, churning out huge amounts of damaging cytokines like TNF and IL-1. The sheer number of macrophages in the synovium correlates very strongly with how much joint erosion we see on X-rays.
And all these activated cells, FLS, macrophages, T cells, B cells, they're constantly talking to each other, right? Via chemical signal.
Absolutely. Through a complex network of cytokines. It's this cascade of inflammatory signals, TNF, IL-1, IL-6, and many others being released, stimulating nearby cells to release more cytokines, creating this self-perpetuating cycle of inflammation and destruction within the joint.
You mentioned IL-6 earlier as being particularly important. Why IL-6?
IL-6 seems to play a really central role in driving many aspects of RA pathogenesis. Its levels correlate strongly with overall disease activity and joint damage. It promotes synovitis, drives pannus formation, stimulates those bone-resorbing cells called osteoclasts, and also promotes the growth of new blood vessels that feed the inflamed tissue. Plus, it drives systemic effects like fatigue and anemia.
Which is why blocking IL-6 is an effective therapy.
Exactly. And understanding the cytokine signaling has been key to developing targeted therapy.
Including the newest class, the JK inhibitors. How do they fit into this cytokine picture?
Well, many of those key cytokines we just mentioned, TNF, IL-6, interferons, etc., deliver their inflammatory message from the outside of the cell to the inside, ultimately telling the nucleus what to do via an intracellular signaling pathway involving enzymes called Janus kinases, or JAKs.
So JKs are like internal messengers.
Precisely, they're critical relay points. The JK inhibitors are small molecules that get inside the cell and block the activity of these JAK enzymes. By doing that, they effectively cut the communication lines for multiple inflammatory cytokines simultaneously, dampening down the whole inflammatory response. That's why they're proving to be quite potent therapies.
Okay, understanding that pathology, the early damage, the cellular players, the cytokines, directly informs how we now treat RA. You stress the urgency. What's the absolute first principle of modern RA management?
Early aggressive treatment with disease-modifying antihermetic drugs, DMARDs. The mandate is to start a DMARD as soon as the diagnosis is reasonably certain, ideally within 3 months of symptoms starting. That early window is absolutely critical.
Why 3 months? Why is that window so important?
Because that's when the irreversible structural damage often starts to accelerate. If we wait longer, we risk letting that damage set in, which we can't undo later. Hitting it hard and early gives us the best chance of preventing long-term disability.
And this urgency is formalized in the treat-to-target T2T strategy. Tell us more about what T2T actually involves in practice.
T2T is essentially a proactive, goal-oriented approach. It means we don't just start a drug and hope for the best. We define a specific target up front, usually clinical remission, or at least low disease activity.
Defined by those composite scores you mentioned.
Exactly, using scores like the DES-28, CDAI, or SDAI. Then, we monitor the patient very closely, typically every 1 to 3 months, initially measuring their disease activity against that target.
And if they're not hitting the target?
Then we adjust the therapy promptly and aggressively. We might increase the dose, add another drug, or switch to a different class of DARND. We keep adjusting until the target is reached and maintained. It's a very dynamic, iterative process.
So what exactly is remission in RA? Does it mean 0 symptoms?
That's a great question. The formal definitions, like the Acreler-Boolean criteria, are quite strict. They require very low counts of tender and swollen joints, a very low patient global assessment score, and a low CRP level.
Okay.
But it's important to recognize that for someone who already has significant joint damage from years of disease, achieving 0 pain or swelling might be impossible, even if the underlying inflammation is completely suppressed. So remission is primarily defined by the absence or near absence of measurable inflammatory activity, not necessarily the complete absence of all symptoms. Low disease activity is often a more realistic target for many long-standing patients. Hashtag tag 4.2 pretreatment safety and monitoring.
Before starting these potent demarters, especially the biologics and JAK inhibitors, there's a lot of safety screening required, right? What are the absolute must-do checks?
Oh, absolutely critical. We're about to deliberately modulate the immune system, so we need to know what we're dealing with. First, screening for chronic viral infections, particularly hepatitis B and hepatitis C, is mandatory. And even more crucial, especially before starting biologics or JK inhibitors, is screening for tuberculosis TB, usually with a blood test like an IgRA or sometimes a skin test.
Why TB? Is reactivation a big risk with these drugs?
It's a significant risk. Many people carry latent TB infection without knowing it. Their immune system keeps it walled off. If you then suppress the immune system strongly with these drugs, that latent TB can reactivate and cause serious, even fatal active TB disease. We absolutely have to screen for and treat latent TB before starting these therapies. It's non-negotiable.
That really drives home the importance. What other baseline risks need assessment?
Given the increased cardiovascular risk in RA, a thorough baseline cardiovascular risk assessment is essential. We need to know their blood pressure, cholesterol, smoking status, etc., especially as some RA treatments, like glucocorticoids, can worsen these risks.
And bone health. You mentioned RA affects bones too.
Yes. Both RA itself and long-term steroid use are major risk factors for osteoporosis and fractures. Patients with RA have a much higher fracture risk, maybe 60 to 100% higher than the general population. So assessing their baseline fracture risk, often with a bone density scan, DXA, is standard practice, especially if steroids are anticipated.
Are there any specific checks needed for particular drug classes?
Yes. Before starting IL-6 inhibitors or JAK inhibitors, we need a baseline lipid panel checking cholesterol and triglycerides. This is because these drug classes can sometimes cause dyslipidemia or abnormal lipid levels, which might need separate management.
Okay, so that's the pretreatment checklist. Once someone is on a DMARD, how often are they being monitored?
Very closely, especially early on or if the disease isn't well controlled. Typically, follow-up visits are scheduled every 1 to 3 months.
And what happens at those visits?
2 main things. We monitor for potential drug toxicity, checking blood counts for bone marrow suppression, liver function tests, and kidney function, creatinine. And we assess disease activity using those composite scores, DACE-28, CDAI, etc., and APRs, CRP, ESR, to see if they're meeting their T2T goal. If not, we adjust the treatment plan right then and there. Hashtag tag 4.3, non-pharmacologic and adjunctive therapies.
We've spent a lot of time on the drugs, the DMARDs. But managing RA effectively isn't just about medication, is it? How important are things like physical therapy or lifestyle changes?
Hugely important. We always emphasize that medication is necessary to control the inflammation and prevent damage, but it's often not sufficient on its own to maximize function and quality of life. A multidisciplinary approach is key.
So what about physical activity? Is it safe for someone with painful, inflamed joints to exercise?
Yes, absolutely. The old advice to just rest is generally discouraged now, except maybe during very acute flares. Regular physical activity is actually beneficial.
How so?
Exercise, including range of motion, strengthening, and aerobic exercises, has been shown to reduce pain, reduce fatigue, improve function, and even potentially lower overall disease activity levels.
What kind of exercise is best?
It needs to be tailored. For joints that are moderately inflamed, isometric exercises where you tense the muscle without moving the joint can be great for building strength without stressing the joint. Low-impact aerobic exercise like swimming or cycling is also usually well tolerated. High-impact activities might need modification if there's significant joint damage. The key is working with a physical therapist to develop a safe and effective plan.
Makes sense. What about diet and weight? Do they play a role?
They do. We know that obesity is linked to higher RA disease activity and significantly predicts a poorer response to many RA treatments, including expensive biologic.
So weight loss can actually improve treatment outcomes.
Yes, studies have shown that weight loss in overweight or obese RA patients can lead to significant improvements in their disease activity scores. Beyond weight, encouraging a generally healthy anti-inflammatory diet pattern like the Mediterranean diet is sensible.
Any specific dietary components or supplements with good evidence?
The strongest evidence is probably for high-dose fish oil, rich in omega-3 fatty acids, EPA and DHA. Some trials suggest that adding high-dose fish oil to standard DMARD therapy can significantly improve symptoms and maybe even increase the chances of achieving remission. Needs high doses, though, typically several grams per day.
Okay. Lastly, let's clarify the role of drugs people often associate with arthritis and NSAIDs, like ibuprofen, and steroids like prednisone. Where do they fit in?
These are primarily symptomatic treatments. NSAIDs and glucocorticoids, steroids, are excellent at reducing pain and inflammation quickly. They make people feel better, sometimes dramatically so. But, and this is crucial, they do not stop the underlying disease progression or prevent long-term joint destruction. They are not DMARDs.
So what are they used for?
They're mainly used as bridging therapy, providing relief in the short term while waiting for the slower-acting DMARDs to kick in, which can take weeks or months. Or they might be used for managing occasional flares or persistent symptoms that aren't fully controlled by DMARDs. But the goal is always to use the lowest effective dose for the shortest possible time, especially with steroids, due to their side effects.
Right, so let's dive into the core treatments, the DMARDs themselves. These are the drugs that actually modify the disease and prevent that long-term damage. We can broadly group them, right? Hashtag 5.1, conventional synthetic DMARDs, CS-DMARDs.
Yes. We usually start with the conventional synthetic DMARDs, or CS-DMARDs, and the undisputed king, the anchor drug in this category, is methotrexate.
Methotrexate, MTX. It's been the first-line choice for decades. How does it work in RA, and what are the big safety considerations?
At the lower doses we use for RA, MTX isn't primarily acting as a cancer drug. It works mainly through various anti-inflammatory mechanisms, including effects on adenosine signaling. It's highly effective at reducing symptoms and, critically, slowing down or stopping the radiographic progression, the joint damage.
But it needs careful handling.
Extremely careful. Regular blood monitoring is essential to check for potential effects on the liver, kidneys, and blood counts, like white cells, red cells, platelets.
And who absolutely should not take it?
Key contraindications include pregnancy or planned pregnancy. It's teratogenic. Also, significant underlying liver disease or excessive alcohol consumption are major no-goes due to the risk of liver toxicity. Patients need to be counseled very carefully about these risks.
If methotrexate alone isn't enough, what's next within the conventional DMARDs?
We often move to combination therapy. Using MTX together with other CSTRNs like sulfasalazine and hydroxychloroquine, often called triple therapy, has been shown in many studies to be more effective than MTX monotherapy for patients who aren't reaching their target. Hashtag 5.2 Biologic, BDMRs.
Okay, so if conventional DMARDs, even in combination, aren't getting the job done, the next step up is usually the biologic DMARDs, or BDMRs. These are engineered proteins targeting specific inflammatory molecules. Let's start with the first class. The TNF inhibitors.
Right. The TNF inhibitors, drugs like adalimumab, etanercept, infliximab, golimumab, certolizumab, were revolutionary when they arrived. They specifically target tumor necrosis factor, TNF, one of those key inflammatory cytokines we discussed. They are very effective at reducing inflammation and significantly slowing or halting erosion progression.
Powerful drugs.
Yeah.
What are the main safety flags or contraindications specific to TNF inhibitors?
Besides the general biologic concerns like infection risk and TB reactivation, two specific ones stand out for TNFs.
Okay.
First, they should generally be avoided in patients with moderate to severe heart failure, New York Heart Association class 3 or 4, as they have been linked to worsening heart failure in some cases.
Okay.
And the second, they are contraindicated in patients with a history of demyelinating diseases like multiple sclerosis, MS. There have been rare reports of new onset or worsening of MS-like symptoms in patients on TNF inhibitors.
Got it. Moving on to another major biologic target, interleukin-6, IL-6.
Yes, the IL-6 receptor inhibitors like tocilizumab and seralutinib. As we discussed, IL-6 is a central player, so blocking its signaling is highly effective for many patients, sometimes even when TNF inhibitors haven't worked.
What specific monitoring is needed for IL-6 inhibitors?
They have their own distinct profile. We need to monitor blood counts, particularly for neutropenia, low neutrophils. Liver enzymes also need regular checks, as elevations can occur. And importantly, we need to monitor lipid profiles, as these drugs can raise cholesterol levels.
Anything else specific to IL-6 blockers?
There's a known, albeit low, risk of gastrointestinal perforations, particularly in patients with a history of diverticulitis. So they're generally used with caution or avoided in individuals with that history. Hashtag tag 5.3, targeted synthetic DMARDs, TSD-MARDs, JAK inhibitors.
Okay, that brings us to the newest major class. The targeted synthetic DMARDs, or TSD-MARDs, which are mostly the JAK inhibitors.
Right. These are different from biologics because they're small molecules taken orally that work inside the cell.
Yep.
Drugs like tofacitinib, baricitinib, upadacitinib, they block those Janus kinase enzymes we talked about, thereby interrupting the signaling pathways for multiple cytokines involved in RA.
They sound very effective, maybe even more so than methotrexate alone in some studies.
They are indeed highly effective, yes, often showing good results even in patients who haven't responded well to biologics.
So if they're oral and highly effective, why aren't they used first line, or at least right after methotrexate fails? Why are they often reserved for after trying a biologic like a TNF inhibitor?
That positioning comes down primarily to safety signals that emerged from large post-marketing studies, particularly one major trial comparing tofacitinib to TNF inhibitors.
What did that trial show? What were the specific concerns?
The trial found that, compared to TNF inhibitors, patients taking tofacitinib, particularly those over 50 with at least one cardiovascular risk factor, had a higher rate of major adverse cardiovascular events, MACCE, things like heart attacks and strokes.
Okay, higher cardiovascular risk. Anything else?
Yes. There is also an increased risk of malignancies, or cancers, observed in the tofacitinib group compared to the TNF inhibitor group in that same high-risk population.
Wow, okay, so MSE and malignancy risks. That obviously changes the calculation.
It does. It led regulatory agencies and guideline committees to generally recommend using JAK inhibitors after an inadequate response to one or sometimes even two biologic DMARDs, especially in patients with those known risk factors. The risk-benefit balance needs careful consideration.
Which means the monitoring for JAK inhibitors has to be particularly stringent.
Absolutely. In addition to the routine blood count, liver, and lipid monitoring, there's a significantly increased risk of herpes zoster or shingles with JAK inhibitors. Yes. So strong recommendations are in place to vaccinate patients against shingles, ideally with the recombinant zoster vaccine, before they start a JAK inhibitor if possible. It's a necessary precaution for this highly effective but also complex class of drugs.
Let's zoom out again and look at the bigger picture, the long term. Modern treatments have clearly improved things dramatically, but does RA still affect how long someone might live?
Unfortunately, yes, it still can. While the gap has narrowed significantly thanks to better treatments like T2T, on average, people with RA still tend to have a slightly shorter lifespan compared to the general population.
And what are the main reasons for that increased mortality? Is it the joint damage itself?
Generally, no. The excess mortality isn't usually directly from the joints. It's driven by the systemic aspects of the disease and its complications.
So what are the big killers?
The three leading causes of excess death in RA patients are cardiovascular disease, heart attacks, strokes, heart failure.
Which we know is linked to the inflammation.
Exactly. Second is respiratory disease, particularly interstitial lung disease, lung scarring, and infections like pneumonia. And third is malignancy, especially certain types of lymphoma, which seem to occur at a slightly higher rate in RA patients. Controlling the systemic inflammation is key to reducing these risks.
Given that outcomes have improved overall, are there still factors that predict a worse prognosis? Things that tell you a particular patient might have a tougher road ahead?
Yes, definitely. We look for several indicators of a potentially poor prognosis.
Such as?
Being seropositive, especially high levels of both RF and ACPA. Persistently high disease activity markers like ESR and CRP despite treatment attempts. Having extra-articular manifestations involvement of organs beyond the joints. having a high number of affected joints initially, polyarticular disease, seeing erosions on x-rays very early in the disease course, and of course continued cigarette smoking is a major negative prognostic factor.
And identifying these factors early helps tailor the treatment intensity.
Absolutely. Patients with these poor prognostic markers are the ones who need the most aggressive T2T strategy right from the start, often involving earlier use of biologics or combination therapies. Hashtag 6.2, the challenge of multimorbidity.
RA is a chronic disease, and people with one chronic condition often have others. How common is multimorbidity, having two or more long-term conditions in people with RA?
It's extremely common, much more common than in the general population. Studies suggest RA patients have more than double the odds of having multimorbidity.
And does having multiple conditions make managing the RA harder?
Immensely harder. It complicates treatment choices, increases the risk of side effects, reduces functional ability, impacts quality of life, and often makes it more difficult to achieve and maintain that low disease activity or remission target for the RA itself. It's a huge challenge.
Let's quickly touch on some of the most important comorbidities again. Cardiovascular disease.
Top of the list. As we've said, RA itself is an independent risk factor for heart attacks, strokes, and also venous thromboembolism, blood clots. Aggressively managing traditional cardiovascular risk factors, blood pressure, lipids, diabetes, smoking, is crucial, alongside controlling the RA inflammation itself. Good RA control actually helps lower the cardiovascular risk.
Bone health, osteoporosis, and fractures.
Another major one. The combination of chronic inflammation and potential steroid use significantly increases fracture risk. Regular screening with bone density scans and preventative measures like calcium, vitamin D, and sometimes specific osteoporosis medications are often necessary.
Infections, especially with all the immunosuppressive drugs.
A constant concern. Both the RA itself and the treatments increase the risk of serious infections. Patient education about recognizing infection symptoms early, appropriate vaccinations like flu, pneumococcal, shingles, and the critical rule of temporarily holding DMARDs during an active serious infection are all vital parts of management.
What about the kidneys? Does RA directly damage them often?
Direct kidney damage from RA itself, like RA-specific glomerulonephritis, is actually quite rare. However, kidney function can decline more rapidly in RA patients, often linked to poorly controlled inflammation or, quite commonly, the long-term use of NSAIDs for pain relief. We also need to watch out for secondary amyloidosis, a rare but serious complication of long-standing severe inflammation where abnormal proteins deposit in the kidneys and other organs.
And finally, diabetes. Any interactions there?
It's complex. Steroids, even short courses, can significantly worsen blood sugar control in people with diabetes. On the other hand, some RA drugs, interestingly, like hydroxychloroquine and maybe TNF inhibitors, might actually have a mild beneficial effect on glucose metabolism or slightly reduce the risk of developing diabetes. So drug choices need to consider the patient's diabetic status. Hashtag tag outro.
This has been an incredibly comprehensive look at rheumatoid arthritis. If we had to boil it down, the key takeaways for you, the listener, really centered on, well, urgency and control, wouldn't you say?
Absolutely. Urgency in diagnosis, urgency in starting effective DMARD treatment, ideally within that crucial 3-month window to prevent damage.
And control, meaning that relentless treat-to-target approach.
Yeah.
Using objective measures, monitoring closely, and adjusting treatment aggressively until that target of remission or low disease activity is achieved and maintained. It's not about just managing symptoms anymore.
Not at all. And remembering it takes a team rheumatologist, primary care, physical therapist, maybe others, addressing not just the joints with pharmacology, but also function through exercise and managing those crucial systemic risks like heart and bone health. The DMARDs stop the damage. Everything else supports the patient.
Right. The journey is clearly becoming more personalized, driven by biomarkers and a deeper understanding of the underlying biology. Which brings us perfectly to our final provocative thought for you to ponder.
We touched on the mounting genetic evidence, particularly around those specific amino acids at HLA-DRB1 positions 11 and 13. Evidence suggesting that seropositive ACPA-positive RA and seronegative ACPA-negative RA might actually be fundamentally distinct diseases at a molecular level. They seem to have different genetic drivers.
So here's the question to leave you with. If the root causes are potentially different, should we continue to lump them together under the single umbrella term rheumatoid arthritis?
Or is the future of rheumatology moving towards a place where we treat ACPA-positive disease and ACPA-negative disease with increasingly distinct pathways, perhaps even abandoning RA as a monolithic diagnosis?
Will treatment become even more precisely tailored, based not just on symptoms, but on your specific genetic profile, your autoantibody status, maybe even your microbiome. The deeper we dive into the science, the more complex and fascinating the picture becomes.